brain is responsible for various mental functions, including memory, language, visuospatial function, concentration, executive function, praxis, which is the ability to carry out complex motor activities, and personality. A subtle decline in cognitive function, like a slowed reaction time, is a common part of normal aging, and usually doesn't impair daily functioning and independence. This is called mild cognitive impairment. On the other hand, if there's a decline in cognitive skill that does impair daily functioning and independence, then it's called dementia. The major risk factor for most forms of dementia is advancing age, but dementia is not considered an inevitable consequence of normal aging. Most of the time, in dementia, a close family member or friend notices the individual's change in cognition. This includes impaired memory, which leads to repeating conversations or misplacing belongings. Language impairment can make it hard to think of common words. Additionally, concentration and executive function are impaired, so individuals have a hard time with complex tasks, like managing their finances. Impairment of praxis leads to an inability to perform complex motor tasks, such as buttoning one's shirt. Visuospatial impairment can lead to an inability to recognize familiar faces or use simple instruments like utensils. Sometimes, family members will notice a change in the individual's personality. To do a neurological examination, the Montreal Cognitive Assessment, or MoCA, or the Mini Mental Status Examination, or MMSE, can be done to assess orientation, registration, recall, attention, and language. For example, orientation is assessed by asking an individual what time it is, where they are, or who the president is. Registration is assessed by telling the individual 3 words, like dog, table, and cake, and then asking them to repeat it immediately. Then they're asked to repeat those 3 words 5 minutes later, which assesses recall. Attention can be assessed by asking individuals to spell a word backwards. Language is tested by asking the individual to name presented objects, repeating a phrase, and following a 3-step command, such as, take this paper, fold it in half, and place it back on the table. Additionally, individuals are asked to obey a command written on a paper, such as, pick up the pen on the table. Finally, individuals are asked to write a sentence and copy an illustration, such as a pentagon. The MMSE totals to 30 points, and a score of less than 24 implies cognitive impairment, which may suggest dementia or delirium, and these can be differentiated by the time course and the clinical context. Now, it's important to differentiate delirium from dementia. Delirium is usually acute in onset, lasts only a couple of hours to days, and the cognitive symptoms fluctuate, meaning they come and go. On the other hand, dementia is usually gradual in onset, can last months to years, and the cognitive symptoms usually progress over time. Also, consciousness and awareness are almost always impaired in delirium. However, they are only impaired in the later stages of dementia. Additionally, delirium usually occurs in the event of an acute insult, such as an infection, electrolyte imbalance, change in medication, or intoxication. It can also be due to a psychiatric condition, like schizophrenia or major depression. In fact, cognitive impairment associated with depression is called pseudodementia. Okay, now dementia can result from reversible and irreversible causes. Some reversible causes include alcohol dependence and various medical conditions, which can be identified with laboratory investigations. It's helpful to send off TSH levels for hypothyroidism, vitamin B12 levels to assess for a deficiency, and a rapid plasma reagent test, or RPR, for syphilis. Another reversible cause is normal pressure hydrocephalus, or NPH, which is caused by abnormal venous drainage of the cerebrospinal fluid, resulting in a backup of fluid and hydrocephalus. Individuals with NPH usually present with a triad of symptoms: dementia, urinary incontinence, and gait disturbance that's described as a magnetic gait because it seems like the person's feet are glued to the ground. A brain MRI shows ventriculomegaly of all the ventricles, a patent cerebral aqueduct, and no signs of cortical atrophy. As suggested from the name, a lumbar puncture will show a normal opening pressure. The good news is that reversible causes can be treated, and when that happens, the dementia symptoms go away. Alcohol dependence can be treated with medications like acamprosate, disulfiram, and naltrexone. Hypothyroidism can be treated with thyroid hormone replacement, vitamin B12 deficiency is treated with vitamin B12 supplementation, and syphilis is treated with penicillin. The treatment for NPH is placing a ventriculoperitoneal shunt, which drains the excess cerebrospinal fluid. Although placement of a ventriculoperitoneal shunt helps improve walking, it does not help improve cognition. Now, let's explore irreversible causes. Alzheimer's disease is by far the most common cause of dementia, accounting for the vast majority of cases. Individuals with Alzheimer's disease usually go through 3 phases. First is the asymptomatic phase, during which there are changes happening at the tissue level but no clinical symptoms. Second is a pre-dementia phase, called mild cognitive impairment, during which there's gradual onset of memory impairment without much impairment in the other cognitive domains, and no impairment in daily functioning. This differs from normal aging because the memory impairment is greater than expected for the individual's age, and eventually progresses to dementia. The third phase is the dementia phase, and that's where individuals develop more significant memory loss, followed by slow, gradual loss of the other cognitive functions, such as language, visuospatial, and executive functions. Now, there are 2 main types of memory: episodic memory, which is memory of events, and semantic memory, which is memory of words and vocabulary. Early on, episodic memory is impaired and semantic memory remains intact. Later on, both episodic and semantic memory get impaired. Episodic memory can be subclassified to be immediate, recent, or long-term. Immediate memory is sometimes called procedural memory, and it's the memory that you use to repeat back a phone number right away. Recent memory is what you use to remember a list of 3 words 5 minutes after you've heard them, like the 3 words from earlier. This is the type of memory that's impaired early on in Alzheimer's disease, because the disease affects the hippocampus first, which is responsible for recent memory. Long-term memory is the memory of events that have occurred years ago, and these are not impaired until late in the course of the disease. For example, an individual with Alzheimer's may remember the details of their wedding 50 years ago, but they won't be able to remember where they were yesterday. The presumptive diagnosis of Alzheimer's disease is made clinically, and investigations are done to exclude reversible causes of dementia. Also, in Alzheimer's disease, a brain CT or MRI can show hippocampal atrophy that can progress to diffuse cortical atrophy. A brain biopsy is the only investigation that would definitively diagnose Alzheimer's disease, but that's invasive and isn't usually done until there's an autopsy after death. It's thought that lower acetylcholine levels may contribute to the cognitive symptoms seen in Alzheimer's disease. So cholinesterase inhibitors like donepezil, rivastigmine, and galantamine can be used for treatment. Side effects from cholinesterase inhibitors include diarrhea, vomiting, syncope, bradycardia, and heart block. In individuals that can't tolerate cholinesterase inhibitors, NMDA receptor antagonists like memantine can be used. Now, combining these 2 types of medication has not been shown to be more effective than cholinesterase inhibitors alone. These medications don't slow the progression of the disease, but they do help mitigate some of the cognitive and behavioral symptoms, making day-to-day life relatively easier for affected individuals. For example, the medication may help the individual recognize family members, which helps strengthen family ties. Finally, depression is common in Alzheimer's disease, and selective serotonin reuptake inhibitors, or SSRIs, are an effective treatment option. Next up is vascular dementia, which is the second most common type of dementia, and it's associated with cerebrovascular disease. Individuals typically have manifestations of atherosclerosis, like hypertension, diabetes, and coronary artery disease. One type of vascular dementia is multi-infarct dementia, which results from multiple strokes and causes a stepwise decline in cognitive function. For example, the individual develops a stroke and as a consequence demonstrates a sudden decline in their memory. Then, in between stroke events, there is no progression of their cognitive dysfunction until another stroke occurs, and they suddenly lose another cognitive domain, such as language, and so on. This pattern is what differentiates it from Alzheimer's disease, in which the decline in cognitive function is steady and gradual. To be clear, simply having a history of strokes and having dementia doesn't mean that it's due to multi-infarct vascular dementia. The key is that the cognitive decline has to be temporally related to the stroke. Another type of vascular dementia that diffusely affects the white matter of the brain is called Binswanger disease, and this is usually characterized by a slowly progressive dementia. In vascular dementia, there are often associated symptoms like urinary incontinence, cranial nerve palsy, and focal neurological deficits. Also, unlike in Alzheimer's disease, where recent memory is usually lost first, the pattern of cognitive decline in vascular dementia varies depending on which area was infarcted. Unfortunately, there is no available treatment that can help reverse vascular dementia. Instead, treatment mainly focuses on preventing another stroke from happening. This includes blood pressure, diabetes and cholesterol control, lifestyle modification such as exercise, dietary changes, and smoking cessation, as well as starting antiplatelet agents like aspirin. Next is frontotemporal dementia, sometimes called Pick's disease. Frontotemporal refers to atrophy of the frontal and temporal lobes, with relative sparing of the other lobes. Individuals with frontotemporal dementia usually present before the age of 65, and early on they have behavioral symptoms with relative sparing of memory. These symptoms include personality changes, impaired judgment, apathy, and disinhibition. Diagnosis is based on a brain CT or MRI, which may also show atrophy of the frontal and temporal lobes. There is no current treatment available that will help delay the progression of frontotemporal dementia. However, selective serotonin reuptake inhibitors can help with the behavioral symptoms, and atypical antipsychotics can also be used for psychosis. Okay, now two very similar types of irreversible dementia syndromes are Parkinson's disease dementia and Lewy body dementia. Both syndromes include dementia and Parkinsonism, a term used to describe the movement disorder in both diseases. The symptoms of Parkinsonism can be remembered with the mnemonic TRAP, T for tremor, R for rigidity, A for akinesia, or bradykinesia, which is absence or slowness of movement, and P is for postural instability. The main difference between Lewy body dementia and Parkinson's disease dementia is the sequence of events. In Parkinson's disease, the symptoms of Parkinsonism usually come first, and it's followed by dementia later on. On the other hand, in Lewy body dementia, the dementia usually comes first, followed by Parkinsonism later on. Occasionally, an individual with Lewy body dementia is incorrectly diagnosed with Parkinson's disease dementia and treated with levodopa, a dopamine agonist. Now, individuals with Lewy body dementia are dopamine sensitive, meaning that it can cause them to have hallucinations, agitation, and confusion. This unique reaction is a clue that the person actually has Lewy body dementia. Other features of Lewy body dementia include recurrent episodes of having vivid visual hallucinations and fluctuating episodic defects in attention and alertness, which may also be confused with delirium. So if an individual has recurrent episodes of delirium with no identifiable cause, they may have Lewy body dementia. It seems that individuals with Lewy body dementia have issues with cholinergic transmission. So cholinesterase inhibitors can help improve the cognitive symptoms, but, like in Alzheimer's disease, they don't slow the disease progression. Also, although it might be intuitive to give antipsychotics like haloperidol or risperidone for the visual hallucinations, these medications should be avoided in Lewy body dementia as they can worsen Parkinsonism. Levodopa actually helps with the motor impairment, but that benefit has to be weighed with the risk of developing delirium. Next, there's Huntington's disease, an autosomal dominant neurodegenerative disorder caused by a trinucleotide repeat of CAG sequences in the Huntington's disease or HD gene. The genetic phenomenon of anticipation is observed, which is an increased number of trinucleotide repeats in subsequent generations. This leads to an earlier onset and more severe presentation of the disease. Individuals often have chorea, which are involuntary, purposeless movements followed by dementia. Diagnosis is confirmed using PCR to detect the HD gene, which shows the CAG repeats. MRI imaging of the brain characteristically shows atrophy of the caudate and putamen and enlargement of the lateral ventricles. There is no treatment for Huntington's disease. Creutzfeldt-Jakob disease, or CJD, is a rare disorder caused by prions, which are infectious, abnormally folded intracellular proteins. Individuals with CJD classically develop rapidly progressive dementia that develops within weeks to months, and is classically associated with myoclonus, a jerking movement of a muscle group. On a brain MRI, CJD classically shows enhancement of the basal ganglia and thalamus. An EEG shows periodic bursts of high-voltage sharp waves. The combination of the clinical presentation in these investigations is usually sufficient to diagnose CJD. If a lumbar puncture is done, there may be elevation of a protein called 14-3-3. Unfortunately, there is no current treatment for CJD. Another form of dementia that occurs after head trauma is chronic traumatic encephalopathy, or CTE, formerly known as dementia pugilistica. CTE usually occurs after repetitive mild head trauma, such as in contact sports like boxing, ice hockey, and American football. Other susceptible individuals include military veterans and victims of domestic abuse. The thing about CTE is that the exact amount of head trauma needed to produce CTE is still unknown. What's interesting is that the tau protein, the same protein that accumulates in Alzheimer's disease, also accumulates in neurons in CTE. CTE usually develops 8 to 10 years after the head trauma experiences, and in the early stages, mood and behavior are particularly affected. This may include attention deficit hyperactivity disorder-like symptoms and depression. Later on, other cognitive domains like memory are affected. Finally, among HIV-infected individuals, there's an irreversible form of dementia called HIV-associated neurocognitive disorder, or HAND. Affected individuals demonstrate impaired memory and attention, along with changes in personality and behavior. HAND usually occurs in those over 50 years old, and with a CD4 positive T cell count below 200. A brain MRI typically shows a diffuse increase in white matter intensity. Alright, as a quick recap. Dementia causes a decline in cognitive domain like memory, language, or executive function that causes impairment in daily functioning. Reversible causes can be evaluated by obtaining TSH levels for hypothyroidism, vitamin B12 levels to assess a deficiency, RPR for syphilis, and brain imaging with CT or MRI for normal pressure hydrocephalus. The most common overall cause of dementia, characterized by gradual loss of memory followed by a decline in other cognitive skills, is Alzheimer's disease. A stepwise deterioration in cognitive function, along with evidence of stroke on brain imaging, equals vascular dementia. Early changes in personality, atrophy in the frontal and temporal lobes, and relative sparing of the other lobes, as well as onset before the age of 65, is frontotemporal dementia, or Pick's disease. Parkinsonism first, followed by dementia, indicates Parkinson's disease dementia. Dementia first, followed by Parkinsonism, along with visual hallucinations, fluctuating cognition, and dopamine sensitivity, is Lewy body dementia. Chorea, dementia, and autosomal dominant patterns of inheritance equals Huntington's disease. Rapidly progressive dementia, myoclonus, basal ganglia, and thalamic enhancement on MRI, periodic sharp waves on EEG, and elevation of cerebrospinal fluid 14-3-3 protein suggests Creutzfeldt-Jakob disease. Finally, when it comes to treatment, cholinesterase inhibitors like donepezil and NMDA antagonists like memantine are used for Alzheimer's disease. Cholinesterase inhibitors are also helpful in Lewy body dementia, and stroke prevention is important for vascular dementia.